My name is Anish Patel. I'm an interventional pain medicine specialist at National Spine and Pain Centers in Maryland, where I serve as the regional medical director and the medical director of the Frederick office. My primary training and certification is in anesthesiology with subspecialty certification in pain medicine. At our clinic here in Frederick, Maryland, we see a number of chronic pain cases ranging from spinal pain in the neck, the middle of the back, and the low back to musculoskeletal pain, osteoarthritic type pain, even cancer-associated pain, and other conditions associated with chronic pain. Initially, pain medicine was probably associated with predominant medication management and maybe very simple procedures such as interlaminar epidural steroid injections for back pain. There's been a real change in the way we treat our patients as to promoting procedures that are more therapeutic and longer lasting and more definitive, as opposed to simply medication management and quote-unquote covering up patients' pain symptoms. Back pain in a pain clinic probably comprises approximately 85% of our volume that comes through our clinic. Of that, it is probably safe to say that a quarter to maybe even a third of those patients suffer from sacroiliac joint disease to some degree, whether it's been diagnosed or not outside of the clinic or by a primary care provider or the referring physician. The sacroiliac joint is immobile, and it serves as a shock absorber to transfer energy from the upper torso into the lower extremities, with slight relative movement of approximately 2 to 4 degrees. In this state, it should not be producing any significant amount of pain. The issue arises when forces acting upon the pelvis, such as compressive forces or shearing forces, allow hypermobility of the joint, in which case the joint should become painful. Some of the most common causes of sacroiliac joint pain are trauma, pregnancy, overuse, and even aging and osteoarthritis. The majority of patients that come in will isolate the pain to the low back. With further questioning and with some diagnostic testing, as well as provocative testing in the office, we can usually isolate it to the SI joint, which is slightly more lateral from the midline, can be unilateral or possibly bilateral based on whether they're feeling or showing pathology in one or both joints. The VYRSApro joint fusion works in essentially two separate ways. The first is mechanical stabilization of the joint with the insertion of the implant. And you can equate this to something similar like a door wedge being placed under a door and being wedged into place and mechanically stabilizing that door open. It's the same thing you're going to appreciate with the initial insertion of the implant. Over time, the allograft material, which is bone graft material in the actual implant, will start to grow and expand and cause an actual fusion between the ilium and the sacral articular surfaces, which allows for the long-term fixation. The reason that I find the Vyrsa to be more effective is probably 3 reasons. Number 1 is the ease of access and the ease of direction of access of the joint. So when you're using the Vyrsa tools for the procedure, we're using the exact same approach that most interventional pain doctors will use during their diagnostic injection. So it makes it a very familiar procedure. Secondly, the Vyrsa implant is the only one that I've seen that's specifically designed for the sacroiliac joint and allows the most surface area to be captured during the procedure. It is also a procedure that only uses a singular approach and a singular insertion as opposed to a dual insertion, which cuts down on our operating room time. And if you cut down on operating room time, you're going to decrease the risk of any complications with this. There are different sizes of the sacroiliac joint based on sex, such as male and female, as well as body habitus and size of the patient. So having the flexibility of a different size graft makes it much more individualized for the specific patient and will highly increase the likelihood of success overall. After the initial 2 to 3 day period where the patients do experience some mild discomfort at the surgical site, quite rapidly they'll start noticing an improvement in their symptoms in what we consider a reduction of their overall pain complaint as per their verbal analog scale. Most of them will start reporting improvement in function within about 5 to 7 days. And every effort is now being made in the world of interventional pain to minimize the opioid burden of our patients to help with the opioid epidemic across our country. We have a number of patients who we've seen who were previously taking daily oral opioid medications for this condition alone, who have either been able to significantly decrease the medication utilization up to maybe even 90%, to be completely off of the medication maybe 2 to 3 weeks post-procedure. I think it's critical at this point that the advanced interventional practitioner become very comfortable with the sacroiliac joint fusion procedure for a number of reasons. First and foremost being that it's becoming a very prevalent condition amongst our patients as we're seeing more and more post-lumbar spine surgery patients coming into our office. Secondly, we owe it to our patient population to be able to provide them with the most definitive care possible. And the advent of sacroiliac joint fusion allows us as interventionalists to provide a definitive treatment for our patients that can provide them lasting relief for extended periods of time, as compared to with repetitive injection therapy, which we've become comfortable and accustomed to.